Okay, so I'm making this video to talk about my NCLEX journey. I graduated in May of 2019, and 7 days later, I had a baby. I did U World, and I scheduled for the end of July, and July came along, and I failed my NCLEX. And I thought it's probably just because I had a baby and I'm sleep deprived. So I scheduled my exam again, and I did U World and I did Marquet. And November came, and I took my exam, and I failed again. So now I was pretty depressed. I was also like embarrassed because, some of my friends had passed, some didn't, but still some were passing, and I wanted to be on my way with my journey. And I was worried because I live in Florida and you only get 3 chances before you have to do a program to be able to test again. And that would take a lot of money and a lot of time. So I started looking for other resources. I'm on all the NCLEX sites, Facebook groups, and I see what everybody says about like board vitals and about all these different programs. And I ended up buying Remar because she had a Black Friday sale, and I started Remar. And the videos were okay. I bought the VT program with the quick fact book, and I was following her schedule, but nothing was really sticking in my head because every time I did like a quiz or something, I had to do it multiple times or listen to the video multiple times. And I was like, I'm not scheduling my exam because I just don't feel confident. Then I came across Alpha Slice, and I saw that on Facebook. And it's crazy because when I saw the video for it, I recognized Mo. I had watched his EKG video for my November exam. And I remember when I had those EKG questions, I was so confident. And I was like, oh, that's the same guy. So I decided to buy Mo's program, and I liked it from the start. Like, I like that every day you have to do the video. I like what he says in the video, how he says you have to push yourself and like you're accountable for yourself, and like I like how he gives you a quote at the end. And then everything that he says on the videos, and especially what he says at the end about like how you're feeling, is exactly how I felt. Like, I just felt like he made that emotional connection with students, especially repeat test takers who feel like they're never going to reach their goal. And then there's Joe, who you communicate with all the time. That's part of the Alpha Slice team. And I love that because I felt like that made having Mo's videos and having someone to talk about like anything that I wasn't sure about made me so confident because there was so much clarity in whatever questions that I would have. And then like I would report to Joe my scores for my exams, and he would tell me like if I was reaching the expectation, and it just made you feel good. And then it also like showed you what you needed to work on, and you were able to talk to like a real person, which is something that the other programs don't offer. So I really like that about the program. I think that Mo teaches you exactly what you need to know, and he really builds that confidence in you because he shows you how to answer questions. And I'm telling you, if you watch his videos, his voice will stick in your head. And when you do test, you will know exactly what to do because you will hear Mo telling you like, this is not what you pick, or this is not this is not how you go about answering the question. This is how you should do it. And I did Mo's program, and I also did the study plan, and I also bought the QBank, and I think all the resources are really great. And I think it's worth every penny, and that everyone should do it. I tested yesterday on February. Not February. I tested yesterday on Good Friday, and I passed my exam, and I'm so happy. And I want everyone to know that you can definitely do it. I had obstacles in my way. It took me a year. I had a baby. My dad actually passed away in the end of November. And I went through all that and I was able to pass through it. And I have to say thank you to Mo and to Joe and the Alpha Slice team because they gave me that confidence. And I was able to pass on my third attempt. And I'm so happy, and you can feel that way too. You just have to follow the program, follow what Mo says, and regardless of your schedule, you can make the time because I made the time and I have 3 kids. So good luck to everybody. I hope this helps somebody.
Hey, welcome back. Listen, I just want to tell you that your story is not that unique. I mean, thousands of nurses had similar experiences, and I bet during this course you will meet someone who was in your shoes one day and then made it and passed their NCLEX, and you are no different. I bet you on my life. You know what? I'll bet you on my life. You will pass your NCLEX on your very next attempt. I have no doubt. Listen, I would like to welcome you to the self-paced virtual trainer, the ultimate algorithm to pass your NCLEX on your very next attempt. And when I say your very next attempt, I literally mean your very next attempt. Listen, the next time you sit for your NCLEX, you're gonna make me proud. You're gonna make the Alpha Slice family proud. You're gonna be an Alpha Slicer, and you will be on this wall of testimonials, wall of fame, and you will be the hero of your own story. Listen, I want you to believe that every single day. I want you to stand in front of the mirror and say, I'm an NCLEX passer. I will pass my NCLEX. No one can stop me from getting that license. When you go to the test center, there's no way you're going out of the test center without your hands raised up high because you already won. You know it in your heart. You passed your NCLEX. The road to become an Alpha Slice is not easy. It's bumpy. Along the way of your NCLEX journey, you're gonna have so many obstacles. I just want you to bring it to your consciousness. Those are just obstacles, and you need to overcome them. You and me, we are here together. You need to overcome those obstacles to be able to continue your NCLEX journey towards your ultimate goal, which is passing your NCLEX. I would like to welcome you to the Alpha Slice family because you are part of the family. Let's start with the first question. A 50-year-old patient who just had a heart attack. He is prescribed enteric-coated aspirin. Which action does the nurse take in this situation? So now I'm gonna look for keywords. Let's read the question again. A 50-year-old patient who just had a heart attack. A heart attack is a keyword. It might not be the most important keyword, but it is the keyword. He is prescribed enteric-coated aspirin. Enteric-coated aspirin is the second keyword, and usually when you see enteric-coated aspirin in an NCLEX question, trust me, this is what they're talking about, which we're gonna discuss on this question. So the 2 keywords that I picked are heart attack and enteric-coated aspirin. And now I'm gonna rephrase the question in my own words, and that's what I'm gonna say. I have a heart attack patient, like a heart attack. He was prescribed enteric-coated aspirin. What does the nurse do in this situation? So I'm looking for the correct information. If you read the question right, it said, which action does the nurse take in this situation? So I want a proper action, a proper intervention. So anything that's not proper, it's not the right answer. So make sure you understand the English terminology, the language. Sometimes they play on it. So here I'm looking for the correct information, not the wrong information. There are 4 options. One of those options is gonna be a correct piece of information. So let's read the options. Administer the aspirin with a lot of water via nasogastric tube. Listen, enteric-coated aspirin cannot be crushed. It cannot be given through an NG tube. So definitely number 1 is wrong. Number 2, obtain a blood type and cross-match for transfusion. Do I need to type and cross-match a patient if I'm gonna give them aspirin? I mean, if you take aspirin for headache, do you go to the lab and get a type and cross? No. So number 2 is wrong. Option number 3, check his past medical history for peptic ulcer disease. I think this might be right because aspirin is not just an antiplatelet aggregation. but it's also an NSAID, which is non-steroidal anti-inflammatory drugs. And non-steroidal anti-inflammatory drugs, they have a side effect that can cause injury to the gastric mucosa and can cause gastric bleeding. So definitely number 3 is right, but I'm gonna look for number 4. Maybe there's something that's more right. Get a 6-lead electrocardiogram prior to administering the aspirin. Come on. Like, if you're giving aspirin to a patient at home, do you go ahead and do an ECG? You don't. So option number 4 is wrong. So the right answer is number 3. Peptic ulcer disease is a contraindication for non-enteric coated aspirin. And now you're gonna tell me, hey Mo, did you notice that in the subject of the question they're talking about enteric coated aspirin? And then in the rationale, they're talking about non-enteric coated aspirin? So yes, of course I noticed. Because I want to teach you 2 things from this question. It's 2 birds in 1 stone. The first thing I want to teach you is enteric coated aspirin cannot be crushed and cannot be given through NG tube. Period. If you have this in the question, the action that you need to do is you need to call the provider and change the order. Right, the second thing I want to tell you is aspirin, it doesn't matter if it's enteric coated or non-enteric coated, it will cause peptic ulcer disease because it works as a systematic effect. Okay? Alright, awesome. I'm gonna show you a cool video about enteric and non-enteric aspirin, so let's see it. So this is the enteric coated aspirin. Anything that says aspirin E or aspirin EC, that's an enteric coated aspirin because it has a coat on the tablet to protect it from the acidity of the stomach. Non-enteric or uncoated aspirin, when it goes to the stomach, it dissolves and then it might cause peptic ulcer disease. So usually drink it with a lot of water if you had to. All right, listen, this is a follow-up question, which I already gave you the answer, but let's go over it again. The patient gets his medication via NG tube. Which medication does the nurse need to call the provider for? All right, let's read the question again and pick up keywords. The patient gets his medication via NG tube. So medication via NG tube is a keyword. Which medication does the nurse need to call the provider for? So calling a provider is a keyword. So my keywords are medication via NG tube and call the provider. Listen, now, if I want to rephrase the question in my own words, this is what I would say. Got a patient, yes, NG tube. I literally visualize a patient with an NG tube. And I'm giving all medication through NG tube. So what is the thing? What is the order that I need to stop, call the provider to change it? Okay? So let's read the options. Number 1, KCl, which is potassium chloride oral solution. So that's liquid. Number 2, phenytoin. Number 3, captopril tablet. Number 4, aspirin EC. Listen, you already know the answer. It's aspirin enteric coated tablet because aspirin enteric coated tablet, I cannot crush it. I need to call the physician and change the order, maybe uncoated aspirin or something else. So the right answer is number 4. Aspirin EC is an enteric coated medication which should not be crushed. The nurse provides pre-op teaching for a patient. Which kind of anesthesia alerts the level of consciousness? Select all that apply. Again, this is a static question where I'm gonna use true or false strategy. But if I wanna look for keywords, I'm gonna read it again. The nurse provides pre-op teaching for a patient. Which kind of anesthesia alerts the level of consciousness? So to me, keywords are anesthesia and then alerts level of consciousness. So there's an anesthetic that I'm gonna give. It's gonna alert the level of consciousness. So which type of anesthesia can alert the level of consciousness? So I already rephrased the question in my own words. And this is the habit that you gotta pick up. So when you read the option, literally, automatically in your brain, you start looking for keywords and then you're gonna read it again and rephrase it in your own mind without even noticing that you're doing it. That's the power of habit. All right, let's read the option and we're gonna treat them as true or false. General anesthesia. All right, let's treat it as true or false. General anesthesia, does it alter the level of consciousness? Of course. Number 2, Topical anesthesia. So topical anesthesia, you usually use it with pediatric population where you're inserting a peripheral IV. So you put an EMLA cream, you leave it for like an hour, and then you try to insert a peripheral IV line. That minimizes the discomfort or the pain for the child. Again, you use it with cancer patients, usually if they have a polycyte, or they call it implantable venous access device. So before accessing the device, you go ahead and put EMLA cream for an hour, and then after that, you access the device. Sometimes the patient put the EMLA cream at home before coming to the test center so that they can save some time. So topical anesthesia, do you lose consciousness? 100% no. So option number 3, regional anesthesia. Do you lose consciousness? Regional anesthesia, sometimes they call it spinal anesthesia, where you lose sensation from part of your body. Usually like the mid half or maybe a leg or something. Do you lose consciousness? So sometimes in C-section surgeries, do you lose consciousness? You don't. So I'm gonna eliminate that because this is false information. Number 4, local anesthesia. Let's say you have a cut, you need to put or insert lidocaine just to do the stitches. You don't lose consciousness, right? Number 5, conscious sedation. And listen, this is a tricky part where a lot of my students start questioning. So if you are not on the coaching program, usually they boom boom text, hey Mo, what do you think? Or me or their coach, hey Mo, like this is conscious sedation and it's not anesthesia. Hey listen, let me explain. There are some drugs that you use in anesthesia that you use in sedation as well. For example, propofol. Propofol, you use it with anesthesia, like general anesthesia. And again, you use it with procedures like a bone marrow aspirate or a bone marrow biopsy. Same thing for ketamine. You use it for general anesthesia and you can use it for general sedation. So do patients lose consciousness? Yes, 100% they do lose consciousness. And conscious sedation alters the level of consciousness. So I'm gonna keep option number 5. So the right answers are 1 and 5. I hope you are picking up the habit of how to break down NCLEX questions. And literally, time is not your enemy. Wrong answers are your enemy. And this is the first time you hear me say it, but time is not your enemy. Only wrong answers are your enemy. So make sure when you are solving an NCLEX question, just imagine yourself, you are in a ring with another fighter. So the question is the fighter, and you need to defeat that fighter to move further in the tournament, right? So you need to make sure that you answer that question right. Time is not your enemy. It doesn't matter if you took 5 minutes or 10 minutes to break down an NCLEX question and get it right. Just treat every question as if your license depends on it. The way I like to visualize it is that there's someone sitting just on the other side of the screen holding my license, waiting for me to answer that question right, to hand me my license. That's how important every NCLEX question is. And the NCLEX test is an endurance test. Sometimes you sit there for long hours, 3 hours, 4 hours, 5 hours. You need to stay sharp during the whole test because it's an endurance test. The moment you lose your sharpness and you're just answering questions without focusing and breaking them down is the moment that you are going to lose the game. All right, let's move to the next question. The nurse provides care for a patient who had an unexpected death during a night shift. The patient has many tubes and drains in place. The nurse is performing postpartum care of the deceased patient. Which action by the nurse is appropriate when managing the tubes prior to scheduled autopsy? All right, I'm gonna read it again and highlight the keywords. Again, you can pause the video, pick up your keywords, and then see if you and me pick up the same keywords, all right? Listen, this is teamwork. So, the nurse provides care for a patient who had an unexpected death during a night shift. Unexpected is a keyword. It is a very important keyword. The patient has many tubes and drains in place. The nurse is performing postpartum care of the deceased patient. Listen, postpartum care is a keyword. Which action by the nurse is appropriate when managing the tubes prior to a scheduled autopsy. Listen, scheduled autopsy is a keyword because doing postpartum care is one thing, and doing postpartum care when you have a scheduled autopsy the next day is a totally different thing because you need to keep all the evidence because there's a suspicion that something happened. The patient did not naturally die. Maybe there's a sentinel event or possibly a homicide. So see, I already rephrased the question without even noticing because I told the story. On a night shift, the patient died unexpectedly. And then the next day, they have a scheduled autopsy. So I need to do postpartum care. So what are the appropriate things that I need to do? So I'm looking for the right piece of information. So I will have 4 options. 3 of them are wrong, and I'm looking for the right option. So I'm gonna read them. Discontinued tubes and drains and sent to autopsy with the body. Option number 2, discontinue tubes and drains and put them in biohazardous bags. 3, keep all tubes and drains in place in patient's body. 4, keep IV tubes in place but remove drains. Listen, whenever you have an autopsy to be done the next day, you don't touch any tubes or IVs, you don't touch anything. You just keep everything in place, you don't touch them, clean the patient, clean the body, wrap it, send it to the mortgage. So the correct answer here is option number 3. If an autopsy is to be performed, any tubes or drains will be left in place to be assessed and cultured, then removed by the medical examiner after they have tested everything and took whatever evidence that they want. Okay? Let's move to the next question.
All right, I hope you are enjoying episode 3 so far. I want to take a quick break and ask you a question just to make sure that you are retaining information. I've got a patient who's 45 years old. He was recently diagnosed with acute coronary syndrome. The patient is already on aspirin. During doctor's rounds, the doctor saw the patient, and when he went outside, he ordered a drug. Which of the following drugs will raise concern? I've got warfarin, I've got ibuprofen, potassium chloride, or furosemide. What do you think is the right answer? Yes, you are 100% correct. Ibuprofen is NSAIDs, which is a non-steroidal anti-inflammatory drug. And one of its side effects, it might cause peptic ulcer. So aspirin and peptic ulcer contraindicated, it's not a good idea. I'm glad you are retaining information. Now let's go ahead and continue episode number 3. I know you're gonna enjoy what's left of it. Let's go.
The nurse auscultates a patient's bowel sounds. Which finding is most important for the nurse to report to a physician? Alright, you know the drill. Pause the video, pick up your keywords, and then check if my keywords and your keywords match. I'm gonna read the question again. The nurse auscultates a patient's bowel sounds. Which finding is most important for the nurse to report to the physician? The keywords that I picked are bowel sounds and most. So if I want to rephrase this question in my own words, I would say, I've got a patient, I'm assessing his bowel sounds. There's something that I will hear that needs to alert me to call a provider and inform him of this situation, right? Let's read the options. Number 1, brute sound over the abdominal aorta. Listen, for the longest time, I used to pronounce this as bruit sounds. I'm Lebanese. In Lebanon, we speak English, French, and Arabic. So bruit sounded French for me. I used to pronounce it as a bruit until I learned it's brute. So brute sound over the abdominal aorta. Number 2, irregular bowel sounds. Number 3, uninterrupted bowel sounds over the ileocecal area. And number 4, absent bowel sounds for a whole 1 minute. Let's start with number 4. Absent bowel sounds for a whole 1 minute. Listen, 1 minute is not enough. If I want to assess bowel sounds, I need to at least listen for 3 to 5 minutes to confirm that I didn't hear anything, okay? So option number three, uninterrupted bowel sounds over the ileocecal area, which is the small intestine, right? Small intestine, you will hear continuously bowel sounds. They do not stop because there's a lot of fluid, liquidish stool material, all right? They're not formed stool as in the large intestine. So I should hear sounds all the time. And option number two, irregular bowel sounds. I mean, bowel sounds are irregular. They are not regular. Like the intestines, they do not move in a regular pattern. So number two is a correct information. So the thing that's gonna alert me is number one, brood sound over the aorta, and that is indicative of abdominal aortic aneurysm, or they call it AAA, right? So let me compare that to patients who are on hemodialysis. Patients who are on hemodialysis and they have a fistula, right? The fistula, if you touch it, you feel a thrill. If you listen to it, you hear a bruit. So the thrill is normal, and hearing a bruit because of the turbulence is normal. But during bowel sounds, hearing a bruit is an indication of abdominal aneurysm that you need to report to the provider right away. This is an emergency. So the right answer here is option number one. A bruit over the aorta indicates turbulence within the aorta. The physician needs to be notified for suspicion of abdominal aortic aneurysm. And let's move to some slides and talk about abdominal aortic aneurysm. Let's go. Abdominal aortic aneurysm, listen, it is the dilatation of the abdominal aorta caused by an alteration in the integrity of its wall. And this is a picture of a normal aorta. This is a normal abdominal aorta, and then another picture of a large abdominal aneurysm, and you can see. And from the inside, it's not dilated. Actually, it's very narrow because on the sides, there's a lot of atherosclerosis. Without treatment, rupture and death will occur. Those taking antihypertensive drugs are at risk for developing AAA. The most common cause of AAA is atherosclerosis. This is a late manifestation of syphilis. Syphilis is a bacterial infection usually spread by sexual contact. It affects internal organs. Signs and symptoms of abdominal aortic aneurysm. Often asymptomatic. People won't even notice that they have abdominal aortic aneurysm. But then they will start feeling some heartbeats in their stomach. And this is real. Abdominal pain or low back pain. Patients feel heartbeat in their abdomen. Bruit heard over abdominal aorta. Pulsation in the upper abdomen. And again, bruit is a swooshing sound that's heard over a constricted artery upon auscultation. Symptoms of rupture usually cause hypovolemic or cardiogenic shock with sudden, severe abdominal pain. And listen, signs of cardiogenic shock could be rapid breathing, severe shortness of breath, tachycardia, loss of consciousness, weak pulses, hypotension, sweating, and pale skin. Listen, rewind the video, write them down, put them in your notes, and make sure you know cardiogenic shock. And later, we're gonna explain it in details. Abdominal aortic aneurysm treatment. Usually it is stenting or open surgical repair with vascular stent graft. For this type of surgery, your doctor will make a large incision in the abdomen to expose the aorta. Once he or she has opened the abdomen, a graft can be used to repair the aneurysm. Open repair remains the standard procedure for an abdominal aortic aneurysm repair. Nursing care and patient teaching. Number one, assess all peripheral pulses and vital signs regularly. Radial, femoral, popliteal artery, posterior tibial, dorsalis pedis. Observe for signs of occlusion after graft. Change in pulses, severe pain, cool to cold extremities below graft, white or blue extremities. Number three, observe renal functioning for signs of kidney damage. Sometimes during surgery, the renal artery gets clamped, and that may result in renal damage. So always monitor urine output. You need to have at least 30 mLs per hour. The color of urine is amber urine. Elevated BUN or creatinine, clearly signs of renal failure. Observe for post-operative ileus. And when we say ileus, that means there's no peristaltic movement in the intestines. So the things that would help is a nasogastric tube to a low continuous suction for 1 to 2 days post-operative. That may prevent the ileus. And then bowel sounds, you need to check them every single shift. And when it comes to bowel sounds, the only time you say negative bowel sounds, like you don't have bowel sounds, is when you listen to the bowel sounds for 3 to 5 minutes. Make sure you listen very closely, and if there's no sound, then you call your physician and you tell them, we don't have any bowel sounds, all right? Listen, that's all you need to know about abdominal aortic aneurysm. Let's move to the next question, and we're gonna talk about peak and trough levels. A patient is scheduled to receive an IV antibiotics Q8 hours. Next dose is at 2 p.m. The patient is prescribed peak and trough blood levels. At which time does the nurse schedule the trough level to be drawn? Oh my God, this is a very important and very common question on your NCLEX. Those are level 1 questions because everyone needs to know peak and trough values, okay? Listen, the next time we're gonna read it, I'm gonna look for keywords, so let's read it together. A patient is scheduled to receive an IV antibiotics Q8 hours. Listen, when it comes to peak and trough, you need to know the route of administration. So in this case, it's IV, right? So IV is one of my keywords. Next dose is at 2 p.m. So I literally need to know when is the next dose. The next dose is at 2 p.m. because that's 2 p.m. Now I want to know where's my peak and where's my trough. The patient is prescribed peak and trough blood levels. At which time does the nurse schedule the trough level to be drawn? So the third keyword is trough level, right? Because they're only asking about the trough level, right? They're not asking about the peak. They literally said, at which time does the nurse schedule the trough level to be drawn? Okay? So 2 p.m., that's my dose. The antibiotic dose is at 2 p.m. Now I need to take my trough level. So the trough level should be before the dose. Peak after the dose. Trough before the dose. When I want to take peak or trough, I need to keep in mind, hey, is this IV? Is this IM? Is this PO, right? It's very rare that you're gonna get PO on your NCLEX question, but definitely it's IV or IM. So that's my 2 p.m. dose, and I need to draw trough. Trough is usually, it doesn't matter if it's IV or IM, it's usually 30 minutes before the dose, ideally. But in case your question said 15 minutes before the dose, then you just take your trough 15 minutes before the dose. So it's anywhere from 30 minutes to 0 minutes before the dose. Right before you take the dose, you need to draw the trough level. So in this case, if we look at the options, 1430, which is after the dose. So we said after the dose is just peak. So definitely I'm gonna cancel number 1. Number 2, 1500. Again, this is after the dose. Number 3, 1330. So that is 30 minutes before the scheduled dose. Scheduled dose is at 2 p.m. This is 1:30, which look legit. And number 4 is at 1400, which is right at the dose. I don't want that. So ideally, it's at 1:30 p.m. So definitely number 3 is the right answer, and then I'm gonna show you a couple of slides where I'm gonna explain where and when to take your peak and trough. So the right answer is number 3, a trough level is drawn approximately 13 minutes before the next dose. Now let's talk about some drug levels. Trough is the lowest level of the drug in the patient's bloodstream and is measured just before the next dose, ideally 30 minutes. But listen, don't get surprised if the timing in the options is just 15 minutes before the dose. If there's no 30 minutes, go ahead and choose the 15 minutes before the scheduled dose. And is measured just before the next dose of medication is administered. Peak is measured after giving the drug. The time of drawing the labs depends on the route of administration. And let me explain. Peak of IV route is drawn 13 minutes after the dose administration is completed. And oh my God, let me explain. Listen, I highlighted the word completed in blue because it is very important. Let us say I'm giving my antibiotics at 2 p.m. over 1 hour, right? So it finishes, it completes at 3 p.m. When do I take my peak? I take it 30 minutes after the completion, right? So I'm gonna take it at 3:30. Let's say the question is saying, I'm giving my antibiotics at 2 p.m. over 30 minutes. When do I take my peak? I take it 30 minutes after completion. So it is completed at 2:30. And then 30 minutes after, it's at 3 p.m. Okay? You get it? Alright, let's move on. The peak of IM route is drawn 60 minutes after administration of the dose. And listen, let's pay attention here. So the IM, let's say I'm giving antibiotics IM at 2 p.m. When do I take the peak? I take the peak after 1 hour. So 1 hour from administration, okay? Because I don't know when it's completed or when it hits the bloodstream, but after administration, I wait for 1 hour and then I take my peak, okay? You got it? Awesome. Let's move on. I've got a question for you which is gonna test you if you understood or not. Let's see. Patient is getting gentamicin IV every 8 hours. The provider orders a gentamicin peak. If the medication is administered at 10 a.m. over 1 hour, pay attention, it's saying over 1 hour. At which time should the nurse draw the gentamicin peak? It's so clear, those are level 1 questions. Let's read it again and pick up the keywords. Patient is getting gentamicin IV every 8 hours. Listen, we've got to stop, right? Is it IM? Is it PO? No, it's saying it's IV. So IV is one of my keywords. The provider orders a gentamicin peak. If the medication is administered at 10 a.m. over 1 hour, listen, that's the time I'm going to give the medication. That's a keyword. And it's going to be given over 1 hour. That's a keyword because I need to know when it's completed because it's IV. So it's going to be given at 10 a.m. Then over 1 hour, it completes at 11 a.m. When do I take my peak? I mean, you already know before even looking at the options. It's at 11:30, right? So let's continue. So 10 a.m. over 1 hour, those are keywords. At which time should the nurse draw the gentamicin peak? Again, peak is a keyword because I want to know, am I taking trough or I'm taking peak? Of course, I'm taking peak. So let's read the option and then pick up the right answer. You already know this. Number 1, 10 a.m. just before giving the dose? Of course not. 12 noon? That's too late. 11:30 a.m.? Bingo! I told you. Not even looking at the option. You already rephrased the question in your own words and you visualize the times and you can pick up the right answer before you even look at the option. So definitely number 3, but let me read number 4. It's 5:30 p.m. just before the next due dose, which is a wrong answer. So the right answer is number 3. Peak concentration occurs 30 minutes after the finish or completion of the administration of the IV drug. All right, let's move on to the next question. The nurse provides care to a new admission. Which action is the best example of culturally appropriate nursing intervention? Very important. Culturally. So let's read the question again and pick up the keywords. The nurse provides care to a new admission. New is a keyword. Which action is the best example of culturally appropriate nursing intervention? Best is a keyword. Culturally appropriate is another keyword. So definitely those are my keywords: new, best, and culturally appropriate nursing intervention. All right, so if I want to rephrase this question in my own words, this is how I would visualize it. So I've got a new admission and I want to do my assessment. So I'm looking at the best ways, at the appropriate ways, the culturally acceptable ways to approach that patient, right? Let's read the options. Assign the family member to most of the patient's personal care. Number 2, take a permission before touching the patient for a physical assessment. Number 3, keep a personal space of 3 feet when assessing the patient. And number 4, keep in mind the patient's ethnicity as the most important factor in planning care. Listen, right off the bat, number 1, assign the family member to most of the patient's care. I mean, I would eliminate that. Why? I mean, there's a keyword. It's a new admission. So a new admission and then I'm gonna assign most of the patient care to the family members? I won't do that. So I'm gonna eliminate this option right away. And then I've got option 3. Keep a personal space of 3 feet when assessing the patient. I mean, how can I do that? Like 3 feet, how can I do that? It's not even possible. How can I assess the patient? Like put my stethoscope and assess the patient from 3 feet? Finally listen to the pulses from 3 feet? Doesn't make sense, right? So definitely I'm gonna cancel number 3 as well. Now let's read number 2 and number 4. Number 2, take a permission before touching the patient for a physical assessment. I mean, that makes sense, right? But listen, taking permission from the patient is not like you go into the patient room and you say, hey, can I touch you? Because I want to do my physical assessment, so I need to touch you on the shoulder, on the neck, on the face, on the chest. I don't do that, right? This is how you do it. Hey, we're gonna do some physical assessment right now. Is it okay with you? Right? Is this the right time? Right? This is taking permission. So when you are a healthcare provider, healthcare professional, you have control, you have authority. When you're talking to a patient, you gotta speak with authority. But again, you're taking permission. This is how you take permission. Hey, let's do something, or not like that, but you gotta say, hey, not let's do, but you're gonna say, hey, all right, hey, if you do it enough times, then it should be, I mean, do I need to edit this? Let's roll with it, all right? So you're gonna say, hey, listen, I need to do, all right. You gotta say, hey, listen, I need to do some physical assessment, listen to your lungs and to your heart. Is that okay with you? Is this the right time, right? This is asking permission, right? I'm not sure if I'm gonna leave this in or I'm gonna edit it out. But number 2 looks legit. Let's read number 4. Keep in mind the patient's ethnicity as the most important factor in planning care. And listen, this is a very tricky option. And most of my students select number 4. And the reason is the word ethnicity. They think this is the most important factor, but then they forget the keywords. One of the keywords is new. So this is a new admission, and ethnicity might not be the most important factor in planning care, especially if the patient has urgent physiological problems and I need to take action and I need to assess the patient, okay? So number 4, I would cancel it just because of the keyword that I have. It's a new admission. So number 3 or number 2 is the right answer. Many cultures consider it disrespectful to touch the patient without asking permission. And again, the way I ask permission is not, hey, can I touch you? I need to assess your chest and abdomen and heart. It's not like that. Nursing care professionals talk with authority, but at the same time, right while you're taking action, you're asking for permission. So you go like this, hey, here we do it again. Here we go again. So you say, hey, I need to assess your chest, your lung sounds, your heart sounds. So this is the right time. And this will conclude our 3rd episode, and we are going to end this session with a quote about perseverance. So our greatest glory is not in never falling, but in rising every time we fall. And I totally understand. You might have failed the NCLEX before, but every time you failed the NCLEX, you went through those feelings of devastation and depression. But guess what? You still went and stood up and went back on your feet and pursued your goal. But this time, what you're doing is you're pursuing your goal with the right resources and the right mindset. Because the next time you will pass your NCLEX without a doubt. And I know that deep in my heart, deep in my soul, and I want you to know that as well. Visualize yourself passing. Listen, perseverance is the key to success in life. It's just like the piñata. If you've ever went to birthday parties where there is a piñata, whatever you pronounce it, you keep hitting the piñata over and over and over again. You know, multiple people are hitting the piñata, but the one who stays to the last keeps hitting it and never giving up. Guess what? The candy will come out and you will get your prize. And the same thing with the NCLEX. Keep studying and putting in the work day in and day out. Be consistent, and guess what? You will pass your freaking NCLEX on your very next attempt. I know that for sure. And listen, if you needed to go back and rewind for the previous 2 minutes and listen to them again, just to drill that in your head, I know for a fact that you are an NCLEX passer. You are putting in the work, and I will accept nothing but you pass your NCLEX on your very next attempt, because you are an alpha slicer, and that's what it is. Let's go.
Hey, I hope you enjoyed episode number 3 and you learned a lot of information and took a lot of notes. Listen, I want to ask you a quick question just to make sure that you are retaining information. A brute sound, is it normal over the abdominal aorta or over the AV fistula? What do you think? Yes, you are right, and I am happy that you are paying attention. Listen, a brute sound or a whooshing sound over the AV fistula indicates that the AV fistula is working just fine. But a brute sound over the abdominal aorta indicates that there is constriction in the artery. All right, listen, let's move on to the next episode. I know you will enjoy it. Let's go.